introduction. I'd like to thank GIS Scientific Committee for giving me the opportunity to be standing in front of you today. And I promise you that the talk will be short and sweet, as short as an alternative access take usually. So I have no disclosure related to this topic. From the recent available data we have, despite technical improvement in the platform that we have in transcatheter heart valve, there's still around 10 to 20% patients remain not eligible for transfemoral TAVI due to peripheral vascular disease. This statement is from the 2016 TVT Registry annual report, and I was not able to find a more recent one to find. I assume that it is less now, but it's still around, I will assume that it's still around 10%. And this is the options that we have for the traditional, let's say, alternative access. As we all know, the TAVI started with transfemoral and transapical. Now transapical is almost obsolete for transcatheter aortic valve implantation. And then we have transaortic came as an option, but this is also slightly being more abandoned. The more surgical, contemporary alternative access are the subclavian, more widely spread, and the transcarotid that is becoming more common nowadays, especially in North America and Europe. And my talk is going to be mainly focusing on those two alternative options. For assessing alternative access, CT scan is mandatory as the transfemoral approach. So you will exclude this patient from having transfemoral approach based on the CT scan most of the time, and then you will assess all the other alternative access that you need, whether it's subclavian or transcarotid, and there might be some adjunct study that you have to do based on which route you use. For transaxillary access, the beauty of this option is that most of the cardiac surgeons are very familiar with the area, familiar with the axillary artery or subclavian artery, depends where you do your cut down, because of the use of this access for cardiopulmonary bypass traditionally during aortic and aortic surgery, aortic arch surgery, and also nowadays more and more we are using it for cardiopulmonary bypass during minimally invasive and robotic surgery for those patients who are not candidate again for transfemoral or FEM bypass or FEM access for cardiopulmonary bypass. In recent TVT registry, there's around 2.5% of patients in United States and North America have transaxillary access for TAVI. It showed significant lower 30-day mortality compared to transapical and transaortic, and this is obviously the reason why transapical became almost a taboo. But also, surprisingly, it shows higher risk of stroke and cerebrovascular adverse event compared to transapical and transaortic. And we'll talk about possible explanation for this in a couple of more slides coming. This is just an example of a transaxillary access. Usually the preferred site is coming from the left, not from the right, because of mimicking. It mimics coming from the arch of the aorta from the transfemoral approach, and it's probably easier. There's less curvature, there's less turn that the delivery system takes, and the implant is usually more straightforward. But also the right side is possible. Sometimes the most difficult cases will be those cases with transverse aorta and horizontal aorta and transverse vertical sinuses. Coming from the right side will be a little bit more challenging, and you'll probably require stiffer wire. We'll spend a couple of more slides on transcarotid, although it's not common, but because it's not familiar, I decided that we probably need to expand a little bit more on this approach. I have myself done around 10 cases during my training for transcarotid. I have not faced any case during my practice that, well, I need to do it. Compared to transaxillary, the carotid artery is more robust, and dealing with carotid artery as a surgeon is more comfortable because of the proximity of the common carotid to the arch. The subclavian is a little bit further away, so the wall is thinner, and it's more prone to injury, let's say, and the rate of repair is usually more than transcarotid. So it is easier. The dissection to achieve carotid artery or to reach the carotid artery is much easier because it's directly under the skin. Vascular surgeons are very expert in going to the carotid artery. Cardiac surgeons are not very well familiarized with this area. That's why probably the uptake is not as quick as we like to see it. But as you can see from the picture in front of you, between the two heads of the sternocleidomastoid muscle, skin incision, and only platysma layer, and then you'll find the carotid sheath. You just have to be aware of the vagus nerve and the carotid artery, the common carotid artery, just right there. Very easy access. It can be done under local anesthesia or general anesthesia. The assessment for transcarotid, obviously, multi-slice CT scan, the CT from your TAVI protocol. You assess the diameter, calcification if present. Most of the time, the base of the carotid is spared from calcification for those patients who have peripheral artery disease. Bilateral duplex ultrasound for the internal carotid and vertebral is a must. Those centers who are expert in transcarotid access advocate that even stenosis up to 70% are not contraindication for transcarotid approach. If they found an area, one of the carotid is disease with 70% or more, they will choose that axis, whether it's right or left carotid, for their approach to maintain the other side for brain perfusion during the procedure. Vertebral artery assessment also is important. You have to have flow in the vertebral artery, either any of them. Even if one of them is occluded, the other one will be most likely enough. If both carotid are equal in size and there's no significant stenosis, or the stenosis are equal, then choosing the right side, the right carotid, is probably better because of the direct access. You come across the innominate artery, which is a bigger artery, so there's no interaction between the delivery sheath or delivery system with the wall of the vessels. Assessment of circle of Willis is a common question when we talk about carotid approach. However, some centers use it, some centers don't use it. There's no consensus. The biggest center in United States where they use carotid access, they don't use routine assessment for circle of Willis with the CT scan. So those are not a contraindication for carotid artery access. Internal carotid occlusion or stenosis, even if more than 70% ipsilateral, is not a contraindication. Patient who had previous stroke or previous endarterectomy also is not a contraindication for carotid access in those expert center, because most of the endarterectomy are done in the distal common carotid to the internal carotid and the axis, as you can see from the previous slide here, is more toward the proximal part of the common carotid, where it's usually spared of disease. The arrangement of the room around during the procedure is a little bit different, and I think it depends whether you come from the left or the right. You arrange the table, the screen most likely is going to be on the other side of the patients. And here's where I think it makes a big difference, and also why we have a little bit of maybe less stroke rate with carotid approach. From the left, we start from the left, from the right of the screen, the axis is done, and then, as you can see from the picture, the distal part is clamped or snared, so there's no flow during the procedure in that side. There's no flow to the brain. The flow is only from the contralateral carotid. Some center measure the pressure distal to that occlusion to confirm that there is intact circle of Willis. So you occlude the carotid where you want to work, and distal to that, if the pressure is more than 30 millimeter of mercury, I just need 2 more minutes, Ziad, if you don't mind. If the pressure is more than 30 millimeter of mercury, that will give you assurance that the circle of Willis is intact and the patient will be okay. And if the patient is awake, you probably can, I don't know if there's assessment, if there's also a good assessment of neurological status. After the procedure is done, the distal part is still clamped, the sheet is taken out, there's still a wire, and then you clamp both sides and you flush the system. You flush distal first and then proximal, and then you clean any debris that have accumulated in the vessel. And that's one of the explanation why transcarotid actually have less stroke rate compared to subclavian. And this recent study was published in 2021 comparing, from TVT again, registry, comparing transcarotid and subclavian artery axis, around 700 propensity matched cohort, more than 700 patient transcarotid axis compared to 1,500 patients with axillary. If you can see in the fourth line, all stroke was 4.2% in transcarotid compared to 7% in axillary approach. And you can see from the left side of the slide that the uptake of carotid actually is quite surprisingly fast among those centers. So the disadvantage of both axes have more proximity to the fluoroscopy. There is more radiation exposure, unfortunately, with those procedures. Longer procedure time was found with transaxillary compared to transcarotid. And again, the stroke rate with transaxillary is a mystery, but I think is something that we have to think about and just invest more time and have more gut to try probably the transcarotid approach. This is just an honorable mention, I think, for transcarotid approach. Again, for the surgeon, is an easy access, especially those minimal invasive surgeon who can do mini sternotomy or right mini thoracotomy. You can find the aorta. The only thing that's special about transaortic is that you really need to, from CT scan, know exactly where you're going to puncture the aorta and have the distance for clearance for the valve from the sheath. So take-home messages: alternative access TAVI is still not widely spread, obviously because of the technical advances of the delivery system we have now. It still can be done safely with very good planning and I think very good discussion with among the TAVI or heart team. The use of available expertise from the surgical team, I think, is the key. And as a cardiologist, the surgeon is your friend. They do have the skills, even if they're not TAVI, to get a TAVI surgeon or TAVI operator to get you a good access. Thank you so much.
Thank you.